Good evening, everyone. Welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Cherie, and I am a health educator at the MS Foundation. I am delighted to introduce our speaker, Ms. Cherie Binns. Today, we're going to be doing Ask the MS Nurse questions. So we're going to be taking all of your questions.
I am delighted to introduce our speaker, Ms. Cherie Binns.
1 second, now it's lagging.
Today we're going to be doing Ask the MS Nurse.
All right, so how we're going to do this is you can ask your questions through the Q&A anonymously if you would like, or you can raise your hand if you're participating through a phone call, or you may ask on Facebook Live and we will ask the questions to Ms. Cherie Binns. So before we start, I would like to introduce her and give her credentials. So Ms. Cherie Binns is a registered nurse with an additional degree in gerontology and is also an internationally certified multiple sclerosis nurse. She's our patient healthcare liaison and a writer for our MS Focus magazine and a regular presenter of patient education programs for the Multiple Sclerosis Foundation. Cherie was diagnosed with relapsing remitting multiple sclerosis in 1994 and has found that adopting some changes in her lifestyle has made her MS much easier to manage. And with that said, I'm going to be handing over this to Ms. Binns and we can start asking the questions.
Thank you. Again, please feel free to type your questions into the chat box or the Q&A. Raise your hand if there's a question that you would like to ask personally, and we will unmute you and let you go ahead and ask your question. While we're waiting, oh, we got one in the Q&A that just popped in. Why do neurologists ask us to walk and to lift our leg? Part of the reason for that is to just monitor to see if there may be a gait issue that might be correctable with some easy intervention with a physical therapist, or just making us aware of the fact that maybe we're dragging a toe as we walk, or maybe we're hiking a hip. Those hip hikes to keep us from catching our toe are the cause of the majority of our back pain and hip pain in people who have MS. They're related to musculoskeletal pain from a gait disturbance. And my personal experience is that I tend not to recognize it myself when it's happening, but a physical therapist does. And usually 1 or 2 sessions with a physical therapist will bring to my attention what is needing to be done to correct that. 2 sessions with a physical therapist will bring to my attention. We're getting a lot of feedback here. Is needing to be done to correct that. Is that coming from your computer, Bhavya?
Yes, it muted. It just automatically turned on the voice, but I think it should be fine now.
Okay. A few more questions have popped in. Vicky, hi, Cherie. What diet and lifestyle changes have you implemented to help your MS? I don't think we have 4 or 5 hours, but basically, in a nutshell, what I did was I eliminated anything that wasn't a whole food. Anything that was processed or pre-prepared didn't get into my refrigerator or onto my cupboards. So I learned, I used to think that it was going to take too much time to prepare food from scratch, and it really doesn't. With 10 or 15 minutes, I can have all of the ingredients ready to go into the pan or into the oven. And most meals are on the table within a half an hour, start to finish. So basically, more fruits and vegetables helps with a lot of things as far as getting things moving. With MS, our GI tract tends to slow. That makes us feel sluggish and more distracted and actually more fatigued. So keeping the GI tract clear naturally with higher fiber helps to move things along. Supplements I really don't do at all, other than vitamin D, which all of us probably are taking, but my doctor checks those levels of vitamin D every 3 months. He wants to see them as close to 70 as possible. Anything below 50, he generally asks me to up the dose of vitamin D or add an extra pill or two each week until my blood's drawn again to see if that helps out. There is no set dose for vitamin D. It's all basically dependent upon what your blood levels are and dependent upon how you respond to the supplements. Some of us respond very, very readily to supplements. Others of us take a while to get regulated. So those sorts of things. I found that actually the big thing that prompted the diet and the movement, exercise changes was getting onto a disease-modifying therapy. I kind of felt after a couple of months on my disease-modifying therapy, the first one that I was on, that I was coming up for air. I had a little bit more energy, and with that energy, it was kind of like a natural push to start preparing food again. And once I sort of had control over what went into my mouth, I continued to feel better enough to start moving slowly. And as I began moving, a lot of that deconditioning that comes from not being physically active began to peel back. And the more I did, the more I was able to do. Lifted my fatigue almost completely. I don't have that bone crushing fatigue all the time anymore, now that I'm eating all natural whole foods and moving. So let's move into Deborah. Let's see. What medications have been found to be effective for those with secondary progressive MS? Rituxan and similar drugs to Rituxan are thought to be helpful. My neurologist has most of his older patients with MS, those over 45 or 50, on Rituxan. Ocrevus was put out for people with primary progressive or with relapsing remitting MS, but not specifically for secondary progressive MS. So there are some neurologists who just won't use it for secondary progressive. However, Rituxan is almost an identical medication, and I'm testimony to the fact that it works really, really well to keep me from sliding back too far. Mazent is another one, and also 3 or 4 other medications that are similar to that. They're very similar to Gilenya. They're generics of Gilenya, but they've been found to be helpful in people who have secondary progressive MS. So let's see, I took the Mavenclad treatment. This is Kevin, from 2018 to 2020. I've completed the dosage. Is there any further part to this treatment? My MRIs came back with no real or new demyelination or damage or change that could be discerned, which is, Kevin, that's exactly what we want to see with Mavenclad. And generally, nothing more is needed after that second round in year 2. People that have had breakthrough disease activity after their treatment with Mavenclad, generally they'll go on to one of the either something like Rituxan or even some of the earlier medications like an interferon, something that's injectable, just to kind of keep the inflammation down in the central nervous system. Michelle, why don't they ask us to walk? Mine hasn't. That's unusual. We don't all have to do the 25-foot timed walk or the 5-minute walk, but I think it's important that your doctor sees you walking. So I'm sorry that your doctor's not doing that. We have an anonymous attendee asking how often should MRIs be done to check for new lesions. My neuro told me in a year he wants another one, and just of my brain, not my spine. Will all lesions on the spine cause symptoms and lesions on the brain won't? All lesions on the spine don't cause symptoms any more than all lesions in the brain cause symptoms. You may have more lesions in your brain than on your spine, and that's a good indicator. And so that's why they're ordering just the brain MRI. When you're new to this, when you're newly diagnosed or when you're changing medicines, they're going to want to do an MRI annually on you, and generally only of the brain, unless you start having new symptoms that would indicate that you've got some new spinal lesions, things like paresthesias in the lower extremities or new weakness in the lower extremities. So lesions in the neck might be borne out by weakness in the hands. So only if you're having new lesions are they going to need to do the spine. The brain should be enough to do that. Let's see. Vicky. Oh, fantastic. I'm a whole food plant-based and feel so healthy. Good for you. Just make sure you're getting the protein that you need. One thing about plant-based diets, we've got all these new products that are hitting the market, plant-based, like Beyond Beef, Beyond Chicken, things like that. Those may be plant-based, but they're also full of all kinds of things that are not whole food. They're full of stabilizers and preservatives and chemicals to enhance the flavor, preserve shelf life. So I would be a little cautious about how much of that you get into your diet. Some of the products that I have used, although they taste wonderful, they actually, I find I gain weight on them. And I'm not sure what that is. I think they may be a little higher in some fats than some of the things that they're trying to replicate. But I also have more fatigue when I put those things in my diet, and I'm wondering for me if it has something to do with the additives that are in there. Ben says, can you recommend an exercise program for patients in a wheelchair? 5 years, primary progressive, self-diagnosed EDSS at 7, lymphedema with pitting. All those things are pretty common. But I would say I can't give you an exercise program to do with this, because your exercise programs to be effective really need to be tailored to you specifically. So a physical therapy consult and get recommendations on what to do, how to do it, how many times a day should you be exercising, that sort of thing. Again, for the lymphedema or the swelling in your feet and legs, need to be really trying to get those feet up for extended periods of time. So if you're just sitting at your computer and there's any way to get your feet up under the desk, if you're sitting watching TV, get those feet up on a hassock or a recliner or even another chair in front of your chair, just to get them draining. Also, I would recommend using some sort of a compression stocking to keep that fluid from just dropping into your feet and lower legs and sitting there. Let's see. J. Sierra, any tips of healing or reducing sensory symptoms after an attack? I still have constant sensory symptoms a year later on my left side, hand, palm, and inside my mouth. Gabapentin and Lyrica don't help. Unfortunately, those drugs don't help everybody. They do help some. I found, some of you have heard me say that I've got a patch on the side of my leg that fires when something touches it. And it initially used to almost drop me to my knees. It just took my breath away when it would hit. It just initially comes on very quickly, and it burns and it stings for several minutes, but then it gradually goes away. I have found that a TENS unit does help to, it's a distraction. The TENS unit gives you a little bit of an electrical current through pads that are placed above and below the nerve area or near the area of pain or neuropathy. And it gives you another, just sort of a buzzing sensation or an intermittent pulsing sensation where the pad is, that sort of takes your mind off or desensitizes that area. It may not actually take the pain away, but it gives you something else to think about that's not painful, but is a stimulus. I've found TENS unit does work very well for that. As far as those sorts of sensations, I would say if you're not on a disease modifying therapy, you need to be on one. And not all of them are as effective in certain individuals as others are. So have that conversation with your doctor and see if it can't be changed up. My experience has been that when I have gone to a different disease modifying therapy, if I'm having something like that, usually that pain begins to resolve. So have that conversation with your doctor. Can you discuss the effects of menopause on MS? This is Cheryl. Our hormones, as most women will tell you, their MS tends to really act up in the few days before their period starts. As hormones change, our symptoms tend to be very suggestive of those hormones. I wouldn't be watching the calendar, and yet I would know it was coming just based upon the way I felt and the intensity of some of the symptoms that were ramping up. So menopause may very well cause those symptoms to ramp up a bit. The thing that for most women is the biggest problem is heat related. Our hormone shifts can cause what we call hot flashes. And I remember the first hot flash I ever had. I was sitting at the desk in my work office, and all of a sudden I felt like from my waist to the top of my head in an instant just got hot, and my glasses fogged up. I began just peeling. Those sorts of things can make our MS symptoms that worsen when we get overheated more prominent. So keeping yourself cool is very helpful. Dressing in layers so that you can peel when those happen, and they tend to be fairly short-lived. So it's not like you're out in 90-degree heat and you need a cooling vest, although some women say that cooling vests really help. I found that just keeping a cooling collar in the door shelf of my freezer helped that a lot. So let's see. Why do nurses make us weigh in before transfusions? I hate getting on the scale. I'm with you. A lot of our medications are dose dependent. So if you are above or below a certain weight range, they may need to adjust the dose of your medicine. That's not a transfusion. A transfusion is blood, so it would be an infusion. You're getting an infusion of a medication like Tysabri or Lemtrada or Ocrevus or something of that nature. And again, it's because those doses are dose dependent. Those of us over a certain weight may find that certain medicines are not effective for us. Certain, like oral contraceptives, for example, need to be a different dosing if you're over 175, 180 pounds, or they're not effective, and there can be breakthrough pregnancies with them. So this is something that if you are considered overweight, there's a conversation that needs to be had with your doctor. The other thing, and I don't like this at all, it's something that has been really kind of in place for the last 15 years or so, is there's a huge focus on BMI or your basal metabolic index, which tells us that you're either underweight, in a normal weight range. Most of us are not in a normal weight range because normal has changed over the last half century since those weight ranges have been set, or if we are overweight or obese. So again, that's why many health insurers will not reimburse the provider if weights are not present in the chart, if a BMI number is not listed in your record. Which shot should I get first, flu or COVID? I need to wait 1 month after my second shingles vaccine, which will be early October. I think I would err towards the COVID vaccine first. I know some practices are giving them both at the same time. It's recommended that you wait a couple of weeks between them. So they're close enough that you can do them, you know, pretty close together. But COVID is far more of a threat to you at the moment than flu is, and we now have a COVID vaccine or booster that has some antibodies towards the Omicron variants, which the others didn't. Diata from Facebook asks, with no new lesions, I have very big problems with my short-term memory and some long-term memory. So is there something I can get or do to keep my memories intact? Memories intact, I find, I was just telling Bhavya before this session began, I have felt like the last maybe 6 months or so, I was losing some short-term memory. I was having some cognitive problems. It turns out that I had a urinary tract infection I didn't know I had. So I think I would let your doctor know that that's the case. Your doctor can do a brief mental assessment on you and refer you to somebody for help with that. I found that with neuropsych testing, I was able to go to a cognitive retrainer, and it was very, very helpful at minimizing distractions, keeping me on schedule, on track, and it really saved my job for an extra couple of years. So ask your doctor about that, let them know. There is no supplement that has been proven to help with memory, despite what some of the ads will say. They're expensive, it's not proven, and I just wouldn't add them to your diet. Okay, let's see. While I am pro-vaccine, this is an anonymous poster. While I am pro-vaccine, I'm a little hesitant to get the newest COVID booster that's now available. Symptoms that landed me in the hospital this past April, then led up to my MS diagnosis in May, started a few days after the COVID booster. Is it common for vaccines to cause flare in symptoms or even a relapse? Or was it the timing of everything for me most likely just coincidental? I would say most likely it was coincidental. Most of us, if we're having any vaccine response, will get a low-grade fever, achy, fatigue is really an issue with the vaccines. Very similar symptoms to COVID itself, although you're not getting anything active with COVID. The thing about the new boosters that's available, the old vaccines were targeted at the shape and configuration of our original COVID virus, the alpha and the beta and the gamma. They lost some of their effectiveness with the Delta. People got it a little bit more easily, but Delta was also more contagious than those first 3 variants. They're not nearly as effective against the Omicron variants. So there's not a big difference in this new vaccine that's got the Omicron variant targeted with it. They're essentially exactly the same thing. They have just tweaked it a little bit. You're not getting any of the COVID virus in this vaccine. And I think you owe it to yourself to protect yourself with this newest vaccine. Stacy says, what precautions do you take for immunosuppression from Ocrevus? Ocrevus, Rituxan, Kesimpta all make it more difficult for our system to mount an immune response. I had COVID myself back in February of 2020 before we ever shut down. And then I had a total of 4 doses of Moderna vaccine, which is double the strength of the Pfizer vaccine, and I still had no antibodies. So Evusheld is an antibody, not a vaccine, but it's an injection of 2 different antibodies, one in each hip. And they help you, they're similar, they're a monoclonal antibody, so they're an engineered antibody that sort of repels that coronavirus with the spikes and keeps it from really attacking the cell. A recent study that came out last week showed that the Evusheld is not as effective against the Omicron variants as it was against previous variants, but it still gives you more protection if you're not developing antibodies from your disease-modifying therapy. The other thing is, despite the fact that CDC says we don't need to be masked anymore around others, I never go anywhere around other people that I don't have a mask on if I'm indoors. And I think that that's going to be a lifelong thing for me, at least as long as I'm on my disease-modifying therapy that keeps me from building those levels, because it's now evident that we're never going to be rid of this virus. It's going to be endemic, just like the flu virus is endemic, and we'll have to get boosted every year. So get your boosters. Probably it's going to be every 6 months for a booster for those of us on this drug. Your Evusheld is every 6 months, and wear a mask indoors all the time. Let's see. Emily says, do you suggest any coping tools for dizziness that a neurologist can't pinpoint the direct cause of? It's not an issue that I've ever had that's been more than transient. It's like if I get a dizzy spell, it will pass pretty quickly. I've found that I personally, like if I tip my head up to kiss my husband and I'm turning it to the side, I'll have this wave of dizziness that if I'm not holding on to something, causes me to lose my balance. So he's learned to hold me while I kiss him. There are some exercises that some physical therapists will give you to deal with what they call labyrinthitis, which is a cause of dizziness in people, regardless of whether or not they have MS. There are inner ear crystals that can settle in a pattern that causes the dizziness or enhances it. And some of these exercises can help to reposition those crystals and make the dizziness a little bit less severe. Let's see. Anonymous again, is there a correlation between the number of O bands in the cerebrospinal fluid and disease severity and or the likelihood of quick progression? No, there's not. The O bands will tell us if you've got an active inflammation ongoing, because we'll see those bands, which are a result of myelin being damaged and being washed into the cerebrospinal fluid. That's very helpful to make a diagnosis of MS. If you are having O bands in your cerebrospinal fluid, the chances are you probably have MS, particularly if there are lesions on your MRI. But there is no correlation between the number and the severity or progression rate of your MS. You could have 30 lesions in your brain and spinal cord and still have a very mild course of MS, particularly if you're on a disease-modifying therapy. Another anonymous, sorry, I missed the opening comments. My question, I was just diagnosed with MS. I had my first Rituxan infusion this week. What can I expect the next day for side effects? And is there anything I can do to help with them? Is vertigo a common symptom of MS, and how to help with symptoms? So we just answered the vertigo question. Rituxan, I am on personally. I have to say that after more than 20 years on disease-modifying therapies. This is the easiest drug I have ever taken with the fewest side effects that are negative. The side effect for Rituxan, for me, is that my relapses have stopped. My symptoms are under control, except if I get sick or if I get overheated. So it's not that they're not there, it's just that they're under control and they're much easier to live with. The next day, nothing. Some people will pre-medicate you with 100 milligrams of Solumedrol, which is, or Solucortef, which is an IV steroid. And for many of us, we tend to get a little hyper. We tend to have some mood swings with it. We tend not to sleep as well. So have that conversation with your doctor and see if they really feel like you need steroid as a pre-medication. My doctor routinely doesn't use those anymore for most people getting that drug. He just basically uses Benadryl and Tylenol. And I've been on this now for close to 8 years, and I really feel like they're extraneous. I don't even need them. There's just nothing. In fact, the next day I have energy that I hadn't had prior to the infusion. And a lot of people on Rituxan will tell you that they begin to feel like they're down a quart when it's a month still waiting to go to their Rituxan infusion. So some people, once they've been on the drug for a while, realize that their body's ready for another dose before it's time for the dose. And the beauty about Rituxan is that it's not fixed on a schedule like its sister drug Ocrevus is. Let's see, scrolling down here. Maria, hi, I'm newly diagnosed, exercising regularly, eating clean. What are some other lifestyle changes you recommend implementing for inflammation reduction and overall well-being? There are certain foods that will trigger an inflammatory response in some of us. And it tends to not be an across-the-board trigger. For about half of us, we may be sensitive to glutens or dairy. And if we eliminate those, it reduces the inflammation. I found when I was in my 40s, 50s, that those things were real triggers, my symptoms getting worse. Since I went through menopause, they're not as severe a trigger. And yet I still find that if I eat, if I have a sandwich 2 days in a row, for example, I will be more fatigued. I'll be a little more itchy. My contacts will goop up and I'll have to take them out and clean them more frequently. So you might try an elimination for a few weeks of either gluten or dairy, and then introduce it back in if you don't notice any difference. And if you're not sensitive to it, you shouldn't notice any problem reintroducing it. But that's the kind of thing that you can tailor to you and to your needs. Barb says, I'm on Tysabri. Neurologist said the next drug, if I needed to switch, would be a chemo treatment. Tysabri is a chemo treatment. Anything that we get as an infusion is a type of chemotherapy. Ocrevus, Rituxan, Lemtrada, even steroids. So I hate that they're using that question or that wording without explaining it to you, because it can raise fears that don't need to be raised. They tend to be very safe, low side effect profiles, well tolerated. So I would not worry about that, Maria. I'm sorry, that wasn't Maria. My screen just scrolled up. That was Barb. And another anonymous attendee, just because I have MS, does that mean I have a disability? I have relapsing remitting, and it's very confusing. No, you don't. The disability comes in when you're no longer able to do the things that you used to do that keep you productive, and you haven't found something else that you can substitute for that to keep you productive, to keep you in the workforce. And there are many of us out here who, for one reason or another, are using a wheelchair. Fewer than 5% of us will ever need a wheelchair because of the new disease-modifying therapies that we've got. If you get onto a therapy as soon as you're diagnosed, you may never need a wheelchair. There's only about a 5% chance that you ever will. So even people in a wheelchair may not be disabled because they're able to do productive work that is enriching to them and helpful to them. They may need a curb cut, or they may need a ramp. That doesn't mean that they're disabled. It may mean that they're differently abled. Daniela, had my first symptoms 3 days after the COVID booster shot. 1 month later led to my clinically isolated syndrome, or CIS, for those of you who may see those initials. Not an anti-vaxxer, but boy, am I hesitant of getting further vaccines. I can see why. However, the information's just really not there in a large enough quantity. I mean, we now have millions and millions of doses of these vaccines out there into arms of people who have various autoimmune disorders, including MS. We have hundreds of thousands of people who have MS that have gotten the vaccines, and it's not made their MS worse or even caused a relapse. It may cause a resumption of symptoms for a few days, but it should not cause a relapse or worsen the MS. So I really encourage you to keep yourself protected as much as possible. Get those vaccines and the boosters. Another anonymous attendee, I struggle most days with fatigue and not being able to keep my eyes open during work. Coffee does help enough to get me through the day, but I've read conflicting things about coffee, and if it's more harmful for people than MS than helpful. Is coffee something we should stay away from? No, no, coffee is preferable if it's working for you to taking a medicine to manage your fatigue. The problem comes if you're drinking it throughout the day and evening and it interferes with your sleep. Recommendations are not to drink coffee after midday. For me, I used to be so sensitive to it that if I had even a cup of decaf in the middle of the afternoon, I would be awake. Decaf has almost as much caffeine as regular coffee. Decaf has about 97% caffeine free, where regular coffee is 94% caffeine free. So there's a very small difference between caffeinated and decaffeinated coffees. So no, keep it up. Use it as you need to for fatigue management and keeping yourself responsible and productive. Another anonymous attendee, I struggle most days with fatigue and not being able to keep my eyes open during work. Okay, same one. We're done with that. And another anonymous, sorry, I saw anonymous. There's a whole string of these. I've had trouble focusing for work, and I got Adderall from my neurologist. Have you seen that as a good tool? It depends on who you ask. For me, I did try it for about a week, and then it took me a month and a half to get my sleep cycle back on schedule. And I can't say that it really helped me to focus work-wise. For some people, it's a miracle drug. So any of the drugs that we take for fatigue, I caution you to take a break from it on non-work days, on days that you don't have to be productive for work, because they tend to be addictive. And they also tend to lose their effectiveness over time. So what's working for you today may not work for you 6 months from now. So use it sparingly so that it doesn't get to the point where you're having a problem with its effectiveness. Another anonymous attendee, I felt so much better on Aubagio. I think because it was a pill every day and it was a constant. I had to go off due to elevated liver enzymes, unfortunately. Now I'm on Tysabri, and a week before the infusion, I'm exhausted. Is this typical? It is for some people on Tysabri. As I mentioned, some people that are taking Rituxan or Ocrevus will also say that they, and the terminology I hear is that they're down a quart. Old car terminology here, feeling like they really need that boost, and usually the infusion will take care of that. Another anonymous user, I'm currently on Kesimpta and doing well. I started losing my hair within the week following my first monthly maintenance dose. This is not listed as a side effect, but I have heard from quite a few other people taking Kesimpta that they are also losing hair. Is hair loss a symptom of MS, or could it very well be a side effect of Kesimpta? I really haven't seen that as a side effect of Kesimpta from the people that I have talked with or the neurologists that I talked to that have prescribed it. Hair loss is often, if you have a relapse, you may start losing your hair 3 months later, and that's very, very normal. Hair loss is often a response to an illness or a stress on the body. It's also fairly common with people who are under a lot of emotional stress. And it can be a sign of the fact that your thyroid may not be functioning correctly. So I definitely would mention this to your doctor and ask about thyroid testing. And just look back three to 4 months and see if there were any stressors or illnesses that you encountered that might be causing the hair loss now. Let's see, Daniela again. How long after stopping a steroid course are you immunosuppressed? I would say it depends on how long the course was and also how high the dose was. If you're getting a gram of IV Solu-Medrol or 1,250 milligrams of oral steroid a day for 5 days, you're probably going to be somewhat immunosuppressed for a good month. I would, again, wear a mask indoors around other people that are not part of your household. An extra layer of protection is for people that live with you. If they're going out of the house to work, it might be wise if they're in an environment where they're next to other people that they also wear a mask to protect you from bringing anything home to you that might be a problem for you. Margie, how about cognition, brain health today if taking a DMT? I'm not sure I understand the question. If you're on a disease-modifying therapy and you're having cognitive decline and you're very aware of this, let your doctor know so that you can be tested and see if there's any intervention that might help you to manage that. None of the drugs that seem to be helpful for memory or cognition in the dementia arena are helpful for MS cognitive changes. So we really need to rely on things like cognitive retraining. There are no drugs at the moment that will help that. So cognitive retraining is really the route to go, and you need to have the testing done in order to determine what needs to be focused on with that. Another anonymous, how long does it take for lesions to go away or turn into a black hole? Again, the black holes we were seeing far more in people that had MS for years before starting a disease-modifying therapy. And for people who, to this day, don't take a disease-modifying therapy because they've heard that the side effects are bad, or they've tried 1 or 2 and they've had poor impact. They haven't been able to manage the side effects, and so they go off of a disease-modifying therapy, and as a result, black holes develop from damage. Lesions tend not to go away. Lesions tend to maybe get smaller, maybe less well-defined. But I still have the original 5 small lesions and one larger lesion in my brain that were diagnosed in 1994. So they're still there, even though I'm very, very stable and doing fine. Renee from Facebook asks, should there be a space of time between Ocrevus and the flu vaccine? Am I also more immune compromised for a short time after Ocrevus? Going to be flying and wondering about the need to wear an N95 mask. I would say absolutely anybody that's on Ocrevus at all needs to be wearing an N95 when they're flying or when they're in crowds of people. Because once you're on Ocrevus, we used to think at the beginning of the pandemic that if we timed our vaccine to be just before, like a month before our infusion, so 5 months after the last infusion, that we had the best chance at mounting an immune response. We now know that for anybody that's been on Ocrevus or Rituxan or Kesimpta for over a year, they're not going to mount that immune response. So the N95 mask is going to be part of our wardrobe as long as we're on these drugs, and for probably 2 or 3 years after we get off of them, because it's going to take that long for our immune systems to mount a response. Really, there's no specific time to get your flu vaccine, but realize that all of our vaccines, shingles vaccine, flu vaccine, a tetanus booster, are not going to have the robust response that we had before going on this category of drugs, also known as B-cell depleters or anti-CD20 drugs. Margie's back again. Does Interstim Medtronic work for MS bladder? Is it worth it if you're 72 years old? I would say it's worth a try. Incontinence is something that oftentimes is undertreated. In some cases, particularly if we're taking oral medications, it can be overtreated to the point where the side effects of the medications are damaging. They're fatiguing, brain fog, dry mouth, dry mucous membranes everywhere. So the Interstim may work for you. The other thing that may work is Botox injections. A lot of people that have had incontinence problems do find that Botox helps, or not necessarily even incontinence, but an overactive bladder, because what Botox does is it sort of shuts off the nerves to the bladder, so you're not feeling the urge to empty your bladder regularly. However, for many people that get that Botox injection, until it begins to wear off, you may need to do some self-catheterization to empty the urine from your bladder. I can tell you that that was a big bugaboo when I was faced with needing to catheterize, but it's really not hard. It's just second nature once you start doing it. So those are conversations to have with both your neurologist and your urologist. All righty, I think, unless we have any new questions that have gone in, I have clicked done on all these that are in the Q&A, and the ones in the chat, Bhavya has put in from Facebook. So does anybody else have a question that needs an answer? And again, if you want to ask it personally, raise your hand and Bhavya will allow you to unmute yourself and ask your question. Oh, looks like one just popped in. Couple popped in. I am 42, so not yet the age that the shingles vaccine is recommended. Should anyone on a DMT, such as Kesimpta, get the shingles vaccine regardless of age? Again, you're not likely to get shingles until you're over 50. statistically, you're not likely. So I would hold off on that. And again, on Kesimpta or Rituxan or Ocrevus, you're not going to have as robust a response to the vaccine. So this should be a conversation that you have with your doctor. Your doctor knows you better than I do and can give you more personalized answer than what I can give you here. And Margie again. Do you always have to self-cath at doing Botox? No. But we don't know until after you've had the injection. So usually they teach you how to do it beforehand so that you can do it if needed after the injection. Many YouTube videos on self-catheterization. Yes, there are. Another anonymous attendee. Can you speak on the treatment that Selma Blair recently underwent and how to prevent this treatment or isn't, how prevalent this treatment is or isn't available in the US? She had what we call HSCT or homologous stem cell transplant. So what they do is they harvest your bone marrow and they spin your stem cells out of that. And then they give you very, very high dose chemotherapy to kill off your immune system. It is horrible. It's extremely difficult to go through and come through. You're probably going to be down and out for 2 or 3 months. You're going to be able to pick up just about anything from anybody. A common cold could land you in the hospital. So it's not something to be undertaken lightly. It's only recommended at this point for people who are young and have had MS for fewer than 5 to 10 years and have failed a couple of disease-modifying therapies already. So for many people, it is quite effective. The majority of people that have had this done see a good response. 6 months or so after you've recovered from this, you're going to start getting stronger. You're going to be able to begin to resume things like walking more readily, more easily. You're going to be able to exercise and get better benefit from your exercise. And for many people, they sort of get back to normal, a baseline normal. But what we've seen over the years, we initially thought when this therapy was in clinical trials that this was a cure for MS. It is not. After about an average of 5 years, some people 4, 4.5, others will go as long as 7 years before they begin to decline and get back to their pre-transplant baseline. So definitely, if you're a young person, if you're under the age of 40, and this is going to keep you in the workforce, I would say definitely have a conversation with your doctor. There are probably 8 or 10 centers around the country that do this, but it's extremely costly. It's about a $500,000 to $1 million procedure, and insurance covers very little of that. So clinical trials were the way to go, and now we're pretty much out of most of those clinical trials, although there are a few. What you want to avoid is stem cell treatments that use adipose stem cells, and those usually have you going to Mexico, or there's actually 3 or 4 places here in the United States that do them, and they cost between $25,000 and $40,000 a treatment, and insurance doesn't cover them. Those are scams. They're bogus, and they can hurt you, even though the testimonials are glowing. So avoid those. I would avoid going outside the US for any of these treatments, just because you don't really know what you're getting. The one place where you might be getting a decent, well-tried technique might be Israel. But again, you're going to have to make a commitment to stay there for months to recover from this course. Cheryl says, About to do my second Ocrevus infusion. In between, I've had both a neck and a lumbar fusion. I have a lot of MS pain. Should I take the booster before or after my next infusion in October? I'd get it before, definitely before, because if your immune system has tapered off because of your Ocrevus, you're more likely to have more of an impact just before an infusion than right after an infusion. But again, if you're only on your second, so I would do it just before the second infusion rather than after. Much better chance of having it work well for you. Wendy says, when being treated for breast cancer surgery, I was told that I will need to have general anesthesia. I was told that this could trigger a relapse. Is this correct? For some people, yes. The surgery could also trigger a relapse in the same way that any trauma can. I've seen people miss a step coming down, miss like the bottom step on the stairs behind me, and start with their MS symptoms within 48 hours. Just that little jar to the spine or to the immune system can trigger a relapse in the same way surgery can, some anesthesias can. However, my experience since I have known that it was MS causing my symptoms, I think I've had 6 surgeries, and my anesthesiologists have been wonderful knowing that. And so they will sometimes use a different medicine, generally something that doesn't require a paralytic. Many anesthesias will sort of partially paralyze muscles so that you don't have a reflex action that causes injury during the surgery. But they can counter that with dose changes in your other medications and not give you a paralytic. And I think we've only got time for maybe 1 or 2 more questions. I have an anonymous. I've got 2 left in the chat or in the Q&A, so those will have to be our last 2. I just wanted to say thank you so much for taking the time to do this Q&A. There's so much to learn, and hearing from a medical expert really helps to ease fears and get answers for questions that pop up in my mind throughout the day. Oh, thank you so much. If you're not on our Multiple Sclerosis Foundation private Facebook group, please do join. I moderate that group. Anytime you need to ask a question, you'll get an answer from me generally within a matter of hours, if not minutes, rarely a day. So come aboard and ask your questions. And finally, from Cheryl, also, I have not felt an improvement from the Ocrevus. Do I need to give it more time, or are my expectations too high? I didn't notice an improvement at all. In fact, I thought I was continuing to go downhill until after the 2nd year was complete. So 4 infusions. I was also going through a time of high stress, and once those stressors got resolved, I was dealing with long distance travel every 4 weeks to tend to healthcare needs for my aging parents. And then both of my parents died within 6 months of each other. And so I started my Ocrevus in the middle of all of this, and not Ocrevus, I'm sorry, Rituxan, which is very like Ocrevus. I started it in the middle of all of that. And it really took 2 full years before I realized I am better. I'm not continuing to decline. So give it time. It's going to take a couple of years, I think, before you see any difference. And you may not actually see an improvement, but you may notice that things aren't getting worse, or certain symptoms have now taken a back seat. Thank you all for your attention to this tonight. We will do this every other month. So just keep your eye out on social media. Get on our mailing list if you're not already there. And if you're not already there, type your contact information into the chat or respond to your registration email with that contact information, and we will get you on our list to keep you in touch. Thank you.
Also, if you missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. And as Cherie said, please reply to your registration email for information on how to access these recordings and to sign up for our newsletter to learn about upcoming events. Our next teleconference is going to be this Thursday, September 15th at 6:30 p.m. I'm so sorry for my dog. Shh. Goodness. It's going to be a town hall with Dr. Aaron Boster. So please bring your questions and we will be ready to answer them. And I just want to sincerely say thank you to all our attendees for your participation, and especially to you, Cherie. Thank you for taking the time out to spend with us and to answer everybody's questions so thoroughly.
Thank you, everybody, because you all made this. Thank you.
Thank you.